Okay, let's go ahead and get started. Hello, everyone, and thank you for joining us for today's 30-minute webinar today. Our topic is how to effectively redirect providers and members. And the goal here is to provide information that helps providers and members better understand and act on lower cost of care options. During today's call, we'll take a few minutes to dive into a brief overview of market challenges. We'll then move into a panel discussion where we'll begin to uncover some best practices and some key considerations as market demands lower cost of care. My name is Matt Waltrich, and I'm Vice President of Payer Sales here at Remit Data. Excuse me. And joining me today are Mike Isaac, our Senior Vice President of Payer Operations, and Dave Prue, a Strategic Reimbursement and Contracting Consultant. And Dave brings some extensive experience today as an executive at a major health plan, so we look forward to Mike and Dave's input on today's call as we get into the panel discussion. Excuse me. So let's start first off by kind of kick this off with some discussion around the market challenge that we all face. Everyone certainly is feeling the pressure of rising costs in healthcare, and as I'm sure you all know well, experts are predicting that medical cost trends are going to continue to rise. So industry pressure to cut those costs is going to continue to escalate. Members are feeling the squeeze, and that goes up the chain to employers and so on to health plans with greater pressure to lower costs. What we're seeing is that as prices rise on medical costs, so goes the cost trend. And as a result, it becomes more and more critical for health plans to really understand where they're paying out hollow dollars for the same outcomes. Having the ability to see that at an episode of care level is becoming a major priority for effectively managing the total cost of care. Some key factors that are contributing to this certainly include the increasing financial responsibility for members as high deductible plans grow. Patients definitely need data to help them understand how they're impacted by provider cost variances and differences for discretionary procedures that providers are offering. CMS certainly has made a major commitment to driving episode of care savings through bundled payments. And as payer and provider contract models evolve, it's becoming more and more common for provider risk-bearing entities like ACOs to seek out ways in which they can better understand major cost drivers that are contributing to cost variances within a common episode. So as you all know, in today's environment, there are dramatic variances in cost of care across providers and procedures by specialty and location. And it's important to ask the question, how can you target and successfully impact the most important cost of care drivers that are affecting your organization and your customers? As a typical example, if we look at knee replacements, orthopedic surgeons often perform a knee replacement at multiple facilities, and they're reimbursed the same regardless of the facility they select. Surgeons are unaware of the reimbursement rates those facilities have negotiated with an individual payer. So when you look at the overall episode cost, you end up with variances as much as 400 to 500% across in-network providers for the same procedure. So how can you effectively identify specialist utilization patterns for these kinds of common episodes that have the greatest overall cost impact? How do you pinpoint those orthopedists that are referring to multiple providers for the same procedure, excuse me, or any specialist for that matter who's following dramatically different post-discharge criteria? So throughout our conversation today, we'll touch on a method for identifying these kinds of cost variances at the episode of care level, and look at how you can drive results through member and provider engagement. Where should you focus? What's the financial impact? And how do you get there? So let's get into our Q&A session here. And we'll start off with a quick framework for the discussion here. So, Mike, I'm going to turn to you to kind of kick us off here. Can you briefly talk about how payers can identify cost of care savings opportunities at an episode of care level, and use this information to identify key providers that they should be targeting?
Sure, Matt. I'd be glad to share a few thoughts along those lines. Payers have long been aware of the variances in their fee schedules, for example, and most payers today also have tools to measure the cost of care for a given patient over the course of treating a condition or disease. What's been missing is the ability to accurately identify episode procedure costs, including all the relevant providers, all the locations of service, and compare those different locations in a normalized manner. And this is challenging. It's challenging to measure accurately in a true apples-to-apples comparison, as it requires a different approach than what is employed with episode treatment groupers, for example. You know, the exciting aspect of normalizing episode procedure costs for comparison purposes is you would also have insight into which components are driving costs at high-priced providers. For example, is it a specific surgeon group? Is it an out-of-network anesthesiologist? Is it the implant cost, et cetera? In addition, you have insight into surgeon site of service data, which is one of a number of levers that can be utilized to really impact cost of care. Comparative episode procedure costs, you know, they're actionable across all the high volume treatment groups, such as diagnostic tests. A few examples may be sleep studies, cardiac stress tests, imaging, outpatient surgeries such as endoscopies, colonoscopies, carpal tunnel surgery are just a few examples. And certainly for inpatient stays for joint replacements, baby deliveries, and spinal fusions, to name just a few. Matt?
Great, thanks, Mike. And Dave, as we're looking at these kinds of particular episodes and targeting providers, can you share some thoughts on engaging providers that you would target within these types of procedures?
Sure, Matt, I'd be happy to. Beyond the traditional payer approaches of educating providers and trying to develop high-performing networks to get to more cost-efficient providers, we're seeing that payers are increasingly moving to provider contracts that are based on more total cost of care accountability, and they're engaging provider groups and health systems in these types of contracts where the groups are actually accountable for the total cost of care for a group of patients. And these contracts provide these health systems and provider groups with an opportunity to share in any cost of care savings for members that are attributed to them. And what we're seeing in these contracts more recently is that the savings potential is significant. It's meaningful revenue for these provider groups. And in these types of situations, what we've also found is that the savings related to episode utilization is really valuable to these groups because it tends to be material and it also tends to be actionable. And as we're seeing these types of contracts expand now to PPO contracts as well as HMO contracts, that universe is bigger. So there's an opportunity to engage providers on a lot of fronts through the usual means, but also through these new total cost of care contracts. Matt?
Excellent. Thanks, Dave. And so in that context, and I guess where applicable, can you speak a little bit to why pre- and post-discharge services, for example, are such important variables in episode of care level price variances and how that's impacted?
Sure, that's a great question. Today, over 20% of hospital discharges require some type of post-acute care, and this percentage is actually even higher. It's close to 40% for Medicare or Medicare Advantage patients. Pre- and post-discharge care can account for over 40% of total episode spending, and post-discharge spending for some common conditions can really vary greatly by provider. That said, we're finding that payers and specialists are often not very aware of both the significance of post-discharge spending, but also the variation of post-discharge cost based on different treatment patterns. And a lot of the post-discharge care that now relates to procedures that are becoming increasingly common, things like joint replacements, where the post-discharge care can be provided in different settings, sometimes at dramatically different cost levels. So this is becoming increasingly relevant to providers who are taking some type of risk for episode costs, whether it's direct risk in a bundled payment contract or risk like I described previously in the total cost of care type situation. Post-discharge cost is a significant item that tends to be very actionable. Matt?
Great, thanks, Dave. So Mike, as we were talking about, actionable opportunities for this type of analysis with site of service, can you speak to what type of opportunities exist to leverage site of service, for example, in prior authorization?
Sure, Matt. That's a really interesting approach, as there have been several transitions in the use of prior authorization over the past 20 years or so by payers. At one time, many procedures required pre-authorization. Then the trend was to scale that back. And in the past couple of years, we've seen a renewed focus on targeted prior authorizations that have a measurable impact on cost of care. Each payer has a different prior authorization strategy that is specific to their market, I would note. But one area that is getting a lot of interest is the fact that many surgeons perform the same procedure at multiple locations, as you alluded to earlier. The surgeon is paid the same no matter where they perform it, and they are unaware in their defense of the price variance among the different locations, and that price difference is often quite substantial. Many payers do see this as an opportunity to, at a minimum, communicate the savings opportunity to the surgeon and or the member, so they are at least aware of the opportunity to reduce the member's out-of-pocket exposure in a substantial way. There are several approaches to implement this that range from proactively educating specific surgeons who represent the most significant savings opportunity to incorporating this information in the pre-authorization workflow. Matt?
Great, thanks, Mike. And Dave, kind of carrying that to you, what are your thoughts on this? How can analyzing provider site of service, for example, during prior authorization really enhance cost savings?
I have a couple thoughts on that, Matt. I think, first of all, payers can address this by adding a softer authorization step to the typical equation that exists today, and that soft step would require the ordering physician to access some basic value information about a service location when ordering a procedure. And if the actual order is ultimately made to a location that is higher cost, then a notification could be given to a member leveraging technology that's available today that lets the member know of that decision and gives the member the opportunity to change the order based on the information that's out there. And the plan, or in some cases a subcontractor of the health plan, can then help the member and the ordering physician switch the referral to a new site and make that change as painless as possible to the member. There's been a lot of data published that confirms that when people are offered comparative pricing, they're willing to make a decision to change, especially if they're comfortable that the quality is equal in the location, and a process like I described can be set up to include quality and make sure that that's addressed. In addition to that idea, payers can take a more direct path, similar to the traditional prior authorization approaches, but in this case, the payer can actually require providers to prior authorize certain ambulatory procedures if they're done in an outpatient hospital setting. In effect, the payer would actually incorporate site of service into their medical necessity reviews and incorporate that into their authorization protocols. That seems to be somewhat of a heavy-handed approach, but we're seeing it in the marketplace with increasing frequency, and we're seeing the list of procedures to which that type of program is applied to increasing by some of the major payers. Matt?
Excellent. Thanks, Dave. Mike, so, as we look at strategies, can you share some thoughts on what factors might limit a health plan's ability to redirect providers and how they would address that?
Sure. I think most all of us within the healthcare ecosystem would agree that our goal is to ultimately help members find the lowest cost, highest quality location for a given procedure. And there's really multiple methods to accomplish that. And methods that would work in one health plan's market may not work for another, and vice versa. A lack of actionable analytics by the payer can certainly be a factor. There are market factors as well that may preclude certain providers from wanting to consider redirection. But in our experience, what has been most effective is a narrowly targeted redirection campaign. It's focused on those providers or those procedures or those settings, as they alluded to. It really represents the largest savings opportunity. And certainly with those providers who are already performing specific procedures at multiple locations with a significant episode procedure price variance. There are certainly instances where a provider may not be receptive, but it's important to make this a win-win situation for the provider. In most cases, we see providers very receptive, as reducing the cost of care ultimately helps their patients while having no impact on that provider's reimbursement. Matt?
Thanks, Mike. So Dave, based on your experience, can you elaborate on that point? And also maybe share some thoughts on what kind of incentives would you see that a health plan could use here?
Yep, happy to. Great question. Plans can apply a variety of different strategies to drive redirection. That can include the basic strategy of creating narrow networks that specifically move more procedures to providers that are more efficient. I mean, that type of strategy is getting more traction as a result of the healthcare exchanges, where you're seeing more narrow network products that are built to drive more aggressive price points. In addition to that, payers in some markets are considering more tiered provider networks, where the member's benefit is richer if they use a preferred provider. That's been shown in some markets to be an effective way to drive the desired level of redirection. And then lastly, going back to a comment I made earlier in the session, I think the adoption of more provider contracts that shift total cost of care accountability to providers, as well as the introduction of bundled payment contracts for common procedures and conditions, both of those types of contracts have been effective at driving the redirection that we're talking about, because it really creates incentives within the provider community that weren't really there before, and we've found that those incentives have been tremendously effective at driving behavior changes when it comes to referral patterns. Matt?
Great, thanks, Dave. So you mentioned, common episodes. Just kind of carrying that thought, are there particular episodes of care or specific specialties that, in your opinion, may be more actionable or impactful than others? And how variable would you anticipate that to be from one health plan to the next?
Well, Matt, I think it really does vary by plan. And ultimately, it's really, really important for plans to complete some comprehensive analysis of their episodes. And I think it's important that they do it from multiple perspectives. I think much of the episode of care analytics that's out there today tends to be ETG-based or very clinically based, and that's important, and that's definitely a key piece of the equation. But it doesn't always provide all of the insight that plans really need to see regarding referral patterns. So I think for that reason, it's important that plans analyze episodes from a variety of different perspectives and really get a good understanding of the different inputs into episode cost and the impact of specific specialist referral patterns on episode cost. So it requires a multifaceted analysis. I mean, ultimately, payers are going to be looking for meaningful and actionable opportunities, and that generally means identifying any episodes that show significant cost variation and that could be addressed through changes in referral patterns. So that's ultimately going to be the most important thing. I mean, there's some episodes that are always going to be at the top of the list. I mean, I think most recently, joint replacements have been a common source for payers when it comes to looking for episode savings, just because of the frequency of the procedure and the cost of the procedure. So that's a common procedure that I suspect would be high on the list of any health plan, though it really is going to vary by health plan, and it requires some really good analytics to really understand where the opportunity is. Most recently, I'm finding that payers are increasingly interested in identifying episode cost differences that are related to things other than just the differences in hospital cost. I think some plans are very aware of the fact that hospital A may cost a lot more than hospital B, and that's obviously going to drive higher episode cost. But they're not as aware of some other subtle differences, like the post-discharge example we talked about previously, or the impact of certain hospital-based physicians, or the impact of pre-admission procedures, things like that. So we're seeing payers focus more on the impact of those types of items, and we're seeing more requests to normalize analysis to really tease out those types of opportunities. Matt?
Very good. Thanks, Dave. Excuse me. Mike, let's shift gears a little bit and talk a bit about the member. Obviously, pricing transparency needs to it's been growing rapidly, as we're seeing in the industry, and especially as member cost sharing increases. What's been missing with these tools, and what's needed to better help members really understand the overarching impact that their provider selection and service decisions have on cost?
Sure. Member pricing transparency has been a challenge for many payers. The if you build it, they will come approach has not worked. Utilization of these payer tools is rather low in many cases. And most payers have not seen a measurable reduction in cost of care by simply providing member pricing transparency information. With that said, the market and members are demanding even greater pricing transparency that is easier to access during that medical decision-making process. In that medical decision-making process, it's usually a very small window in time. The member may be in front of their doctor discussing options of where to have a test ran or a procedure performed. The right information has to be easily accessible and easily digestible at the right time. It also has to be specific to the member's network and health plan. Tools that meet these criteria are seeing higher utilization rates, higher member satisfaction, and sustained savings. And I think it's also important to note that in order to maximize savings, we do need an all-of-the-above approach. Payers need to continue working upstream of the medical decision-making process to help guide the member to low-cost, high-quality providers, so we're not solely relying on that member during what is often a stressful or alarming medical situation to make that high-value medical decision. Matt?
Excellent. Thanks, Mike. So we have kind of run through the questions that we had. What we'd like to do now is open this up to Q&A from our audience. We have a few minutes left until the top of the half hour here. And so if you have any questions, certainly feel free to ask them. It looks like we have one or two so far. So I'm going to start with the first one that we have here. So Mike and Dave, I'll read this to you, and certainly feel free to chime in with your thoughts. Currently, my organization is on a very tight budget, and our internal resources are maxed out. Are there other options available for organizations like mine, or would we need a big budget to implement redirection strategies? I think just, some thoughts that I would like to reflect. I think certainly this you can start, in some very specific areas that would not necessarily require a major budget to implement. It's definitely something that can be approached incrementally and strategically when you identify sort of the highest opportunities for cost saving based on key targeted episodes and the providers that are driving those cost variances. It can be a very selective and very strategic approach. Mike, kind of turn that over to you. I'd love to kind of get your thoughts on that as well.
Sure, and it's a great question, and it's really a common theme. Budgets are often tight in healthcare because we do have so many competing priorities and all very important priorities. My initial thought is around the fact that we're seeing a lot of interest in the industry around a shared savings model, i.e., hey, partner, when you deliver the savings that's measurable, then that would free up the resources to actually compensate you for the service. So, that would definitely be one strategy, that could be a very viable option, especially, as budgets are tight with certain payers.
Okay. Dave, any thoughts you'd like to share on that also?
I echo Mike's comments. I also would recommend focusing on some of the higher volume procedures that, where you're going to have a good degree of volume and you're going to have some variation in cost, and just understand site of service patterns for those procedures. I think in many cases plans are pleasantly surprised at some of the actionable opportunities that they can identify just through some first-level analysis and understanding what's going on, and some of it can happen just through provider education.
Absolutely. Okay, I think we may have time for just one more question here. Let me read this. Our processes are set, and we like our current care management system. How would these strategies work within our current systems? So I think that sort of speaks to the care management workflow process, and certainly you could tie that back to the example of prior authorization, where the ability to give the review staff the opportunity to see or research lower cost of care setting opportunities at the time that prior authorization is coming in. That is certainly something that can be integrated within the care management workflow tool itself, or based on the workflow process, could be aligned with the steps that the review staff is taking. Mike, I don't know if you have any additional thoughts on that you'd like to share.
Sure, and I think that's another common trend is, hey, we do have processes in place, we have care management workflows in place, and a large part of the organization may already be using those. A couple thoughts come to mind. One, as you mentioned, Matt, integrating this information into the existing workflow, kind of drives maximum savings with least disruption. But in addition, I would echo a point that Dave made earlier, is, a substantial portion of these savings we see is available from a very select targeted group of providers, for some really highly targeted procedures when you have the right supporting analytics. So, if a payer does in fact want to tweak their workflow, that may be a longer process, but there's opportunity, near term, by leveraging this information with very targeted, specific, even provider outreach, provider communication, provider education, really targeting certain use cases, certain procedures, and certain redirection opportunities. And that's low-hanging fruit that requires very low effort.
Absolutely. Thanks, Mike. All right, well, that kind of brings us to the end of the half hour here. So we hope you found this Q&A beneficial. And if there are any additional questions that we did not get to on the call today, certainly feel free to email them to us. You can reach us at marketing@remitdata.com, or as you see my email address here, certainly feel free to reach out to me directly at mwaltrich@remitdata.com. or if you'd like to schedule some time for a more thorough discussion on the topics that we talked about here today, we'd be happy to do that with you as well. In follow-up to this, we'll be emailing a FAQ and a recorded copy of the webinar so that you have that available. Please join us for the next webinar, where we're going to be diving further into provider site of service savings opportunities and explore the benefit of analyzing the complete episode of care costs. So the date and time of that will be announced. You'll receive an email, and we hope you will be able to join us. So have a great day, and again, thank you all for joining us today.